Great. Hello, everyone. We'd like to welcome all of you to the first of two sessions that the Erie County Workforce Collaborative Training Series that we're having in April. The Erie County Department of Mental Health is happy to be able to offer these trainings to our dedicated providers in our community to support workforce retention and provide an opportunity for individuals from our provider community to share their expertise. Today, we're excited to have Andrea Tobias, our Assistant SPOA Coordinator from Erie County Department of Mental Health, with us to speak on making a care management SPOA referral. At the end of this session, we will be asking everyone to complete a very brief evaluation. We hope you will take a moment to fill this out so we can continue to improve. We are excited that we're offering two trainings this month. Our second training will be on Tuesday, April 25th from 12 noon until 1 p.m. on barriers to reentry with Juliana Everdike from Erie County Department of Mental Health, our Director of Dual Recovery and Community Reintegration, along with Lindsay Allen, Director of Community Programs from Project Blue and Empower Youth at Peace Prince of West New York, and Tanya Drake, Erie County Reentry Task Force Coordinator. This is our regularly scheduled Tuesday. In May, we will be having Melinda Dubois, Executive Director of Mental Health Advocates. She'll be joining us for a presentation on self-care, the mind-body connection. This will be Tuesday, May 23rd from 12 noon until 1 o'clock. We encourage everyone to share this information with their coworkers, colleagues, other providers in the community, encourage them to attend. We have great presenters coming up that have a wealth of knowledge to share. We will put the links for these registrations for our next two sessions in the chat at the end of this session. We will also be sending out the announcements, or you can always go to our erie.gov/mental health website for these announcements and registration information. Most of our sessions continue to be the fourth Tuesday of the month from 12 noon until 1 p.m. I encourage you to mark your calendars and watch for our future notices. All of our presentations and recordings for our past offerings are posted on our website, so we'd encourage everyone to check those out as well. This is a community collaborative, and we are always looking for volunteers to share their expertise and knowledge with our community of providers. If you are interested in doing a 1-hour presentation, if you know someone who is, or if you're interested in a particular topic, please put that on your evaluation, or you can email Amy at amy.rockwood@erie.gov. Our training today is being recorded. Everyone is muted, so if you have questions, please put them in the chat box. I'll be monitoring the chat during this presentation, and Andrea will be answering questions as we go along. Again, thank you all for joining us today, and I'd like to introduce Andrea Tobias for her presentation on making a care management SPOA referral. Thanks so much for joining us, Andrea. It's all yours.
Thank you so much, Kathleen. Thank you everyone for being here today. We really appreciate you taking your time to join us during the lunch hour. As Kathleen said, put questions in the chat. She will monitor it and kind of let me know as we go what questions pop up. Okay, so we're here today to talk about making a care management ACT and AOT referral in the SPOA website. Okay, so when is a referral appropriate? So for general care management, there are certain criteria or things we look at when we're reviewing referrals. One is that the individual is diagnosed with a serious mental illness, schizophrenia disorder, schizoaffective disorder, delusional disorder, psychotic disorder, major depressive disorder, bipolar disorder, and post-traumatic stress disorder. Those are the main serious mental illnesses that we do accept when we are reviewing referrals. They are found to be in need of added support in the community due to high risk of further system utilization, meaning possible high presentations at a CPAP, high inpatient hospitalizations, a lot of crisis services involvement or police involvement. and they've been unable to maintain community-based linkages and important supports. So kind of going in and out of clinic, in and out of different services that they might already be working with in the community. So when is an assertive community treatment or ACT referral appropriate? So the same criteria that we just spoke about is definitely a big piece of what we'd be looking at for these referrals. ACT, for those who might not be super familiar, is a community-based treatment. The treatment goes to the individual rather than the individual going to the treatment. The individual should have demonstrated difficulty in accessing or engaging with traditional service delivery models, such as the clinic model, and at least 2 of the following. 3 inpatient hospitalizations in the past 12 months, at least 2 readmissions to a psychiatric hospital within 30 days, meaning they were in the hospital, got out, and then ended up back in twice within 30 days. Utilization of crisis services 3 times in any 30-day period in the past 6 months. Severe major psychiatric symptoms, suicidal, psychotic, homicidal, etc. Those individuals that have a mental illness with a substance use disorder that has been lasted for more than 6 months. Involvement or high risk of being involved in the criminal justice system within the last 6 months, and homeless, at risk of homelessness or living in substandard housing. So when we're looking at ACT referrals, we're looking again that they meet the criteria we spoke about on the page before, the care management criteria. Difficulty with traditional delivery service models. We want to know that they've tried the typical clinic setting before we consider an ACT model for the individual, and then at least 2 of those criteria listed below there.
Andrea, we do have one question that just came in. They asked, do they need to have an eviction notice to be considered at risk of homelessness?
Not for something like an ACT referral. No, we wouldn't require anything like that. No, good question though.
Thanks.
Okay, so assisted outpatient treatment or AOT, when is a referral appropriate for this level of service? So the criteria set down by New York State for assisted outpatient treatment is pretty strict, and it is as follows: 18 years or older and diagnosed with a mental illness. They are determined clinically to be unlikely to survive in the community without supervision. The individual must have a history of non-compliance with treatment, and that's a documented history, or a mental illness, which has led to either 2 hospitalizations for mental illness in the 3 years before the referral, or at least 1 act of violence towards self or others, or threats of serious physical harm to self or others within the 4 years prior to the referral. The person must be determined unlikely to accept the treatment recommended in a treatment plan. They must be determined in need of assisted outpatient treatment in order to avoid a relapse or deterioration that would then result in harm to themselves or others. And the person also should be determined likely to benefit from assisted outpatient treatment as well. Okay, so the making a referral process. I'm going to go through a couple main points here, and then I'm actually going to pull up the website and kind of walk through it quickly with you guys as well. So it's eriespoa.org. That is the website. Referral submissions on the top banner. You can log in, whether you have an existing sign in or you can sign up. There's a create a referral area. You upload the SPOA consent. You're going to hear me say that over and over through this training because that's super important, the consent. And then we're going to be choosing the care level and care status. We ask that all fields be filled in, be thorough. More information is better than not enough. If you don't know if you should or shouldn't put it in. We want as much as you will give us. A risk score is generated based on the information that's been providing, and this helps us when we're assigning to the proper care level in a timely manner. Instances of lethality, we're going to go over this a little bit more too. It is not a required field, but we do want it to be filled out, even if the answer is, I don't know. And then the finish and submit referral will show you where everything is for that. So I'm going to go ahead and pull up the SPOA website. Is that good? You guys see it?
Yep.
Okay. All right, so this should probably look familiar to a lot of you guys. So you're gonna go in and log in. And actually, I'm sorry, we're gonna go to referral submissions instead. Apologize if it runs slow. Our internet is not the best ever here. Okay, so you guys as signing in as referral sources will go right here and either sign in, like I said, with an existing user ID password, or you can sign up down here. There's a sign up button. Because I'm an admin, I'll be going just in a different area. So. Okay, so we are on the referral submissions page. And we are going to pick create a referral on the top banner. And then right away here, you're going to see the major diagnoses that we do look for and accept. They are not limited to these, but these are the main ones that we see come through. But of course, I had discussed the other few as well before. And you will see put in here several times, a consent is needed. Referrals without a consent will be delayed. It's very important to us here that we have that consent. So they ask that you upload it right here.
Andrea, one question that actually came in about consent. Someone asked, how do we submit a referral if a patient is too psychotic to consent?
Yeah, so unfortunately, the consent is required. It's needed for a care management and ACT referral. So the best suggestion would be wait until they are more stable and willing and able to sign. For an AOT referral, it's a little bit different where we do have the option and opportunity to subpoena for records if the client will not sign. But that's that's a whole different process that involves having a medical doctor who's agreeable to signing off on the subpoena and possibly presenting to court if needed. It's a longer process. So for AOT, that is something we can do. For general care management and ACT, not connected to AOT, because it is a completely voluntary service, the individual has to be willing to sign the consent. And very good question though. So we're starting on the first page here. So state prison release, that can be ignored unless you guys are from the state prison. Those are just kind of a little bit of a different process for us. And then when you click care coordination here, it's going to ask you to select your care level and your care status. And, these are two big things that we're always looking at. It kind of, depends who is actually working on the referral as far as which level and which status is chosen. So the care level, there are two. It is care management or it's ACT. Those are the two particular levels for that. And then the care status is general or AOT. So AOT is you are asking for a court order for mental health treatment for the person. You have determined that they likely meet the criteria that we spoke about a couple slides ago. General is just the basic. They're voluntarily, they want the assistance, and you're looking for either care management or ACT. And again, please put questions in the chat if I'm using any terms that might not be super familiar to you. I welcome that, but I'm not gonna, explain everything if I don't need to, just to waste your guys' time. So Okay, so we are not going over housing today because that is not my specialty. So any housing questions at the end of this training, I will direct you where you can go for more information on that. So I'm going to skip over anything housing related. So, all right, and here we go. Here's the basic, here's your information, right? So your name, your organization, it's set up pretty great. You can type in your agency, put it right in there. Your title, your phone number, your email. You can refer on behalf of someone else. So, you know, we see that happen a lot with the hospitals where one social worker is making a referral for another one. So you can do that where you just put in who you're referring for their information there as well. So here is where we get into client demographics. I'm just going to put random stuff in so we can move along, but make sure everything is provided. If you do have the social security and date of birth, please give us both. It does give you the option to give one or the other, but provide again as much as you possibly can. So phone number can be added in here as well. I didn't do that right. Okay, so current linkages. You would like to add a current linkage. We would always hope that you would if they have them. So if you are, let's say, a housing worker making a referral for a care manager, please put in their clinic that they might be linked to, just so we have as much information as we can have. So most of them are listed there, what we're looking for. Who are we, you know, contacting, who's their counselor, and then in the notes, put again, as much information as you can, like, you know, John Doe goes to Best Self to see a counselor for depression and substance use, whatever kind of extra information you can provide. And also, if you have the phone number or the address of whatever clinic or whatever care provider this is, that can be added in the notes as well. And they're asking here, is a client currently served with an AOT court order? And that's very small, but that's a very important piece of information there. If they are already served with a court order, we would want to know that when we're getting the referral, especially on the housing side, because that does make a difference with housing and how the people get assigned through there. Okay, so add another linkage. You can keep adding in if you want to put their, you know, their primary doctor in, whatever other, a peer specialist, a family member, any other information, just keep putting yes. We're going to go no for sake of time. Okay, so where do they live? We want to know, do they live alone? Who do they live with? Are they homeless? It's important that we know that information. Homeless, start date, you know, to the best of your knowledge. It doesn't have to be exact. The actual address, we would want there. And if they are homeless, be super important to tell us where they hang out. So are they typically at the bus station between this hour and this hour, and their friend, you know, who is with them often has a phone and can be reached. So any information that will help the agency that gets the referral be able to locate the person. Any other notes too, you know, if they live in a private residence with a spouse or partner, but let's say spouse is abusive and shouldn't know who the person is that's coming to see them, that would be a good note too. Anything you can provide. Okay, so functional strengths and deficits. So I think it's really easy to either skip over this part or to just hit unknown on these. I'm sure that I probably did it when I've made referrals in the past because it's just easier, but these referrals are going to agencies that want to help the person. So again, as much information as you can possibly provide so that they have an idea of who they're working with prior to going out there and meeting the person. We would want that. So as much as you can give us, just letting us know kind of what their skills and their daily activities of living are like. So be as thorough as you can. Instances of lethality. This is a big one. So we want to know this. This will really make a difference to the team that's going to link with the person again, who's going out to see the person. We want them to know if this person has a history of assault. Do they have a history of fire setting? history of sexually abusing others, any kind of other inappropriate behaviors. We want to know these so that the team, again, the ACT team or the care manager, is fully aware of what they're walking into. This section is not, it is not a required field, and that is something that we do want to work on in our office and actually make it a required field, because it gets skipped more often than not, because you don't have to fill it out. So yes, no, don't know, fill out as much as you possibly can. So here you can add more. So add another legal lethality event. I think, yeah, I think you can be more kind of detailed in here too, like if it's something that maybe wasn't in the previous checkboxes, you could be more detailed in different incidences here too. So definitely add in as much as you can there. Okay, insurance. If you have it, give it to us. It really determines what where we can assign them, what services they can have, especially if there's a managed care, we want to know that. Start date, it's difficult to really find that out sometimes, so just pick, pick the closest that you can. Okay, so diagnoses, we do have the specific diagnoses here that are typically required for us to accept a referral. So you would check box one of those, and then down here you can add in more, such as extra additional diagnoses they might have. If there is, if their main diagnosis is one that isn't listed there, you could write it in there instead of checkboxing. Okay, substance use, alcohol use, we want to know if that is a factor. It will not prevent them from getting any services as long as there is a serious mental illness along with it, but we want to know of any substance use issues or concerns. Hospital and emergency room, super important. We want to know of hospitalizations. As far back as you can go, if you're putting in an AOT referral, we want to know for the last 3 years, where have they been? We need to know where to request records from to review for AOT criteria. So definitely put that information in to the best of your ability. We just had one that came through yesterday that the individual had been hospitalized in Alabama and Tennessee, and the referral source was an ECMC social worker. She was fantastic. She put the information in. She had all of the addresses of the hospitals, the fax numbers, the phone numbers. We requested records yesterday, and we already got them from a random hospital in Alabama. So the better and more information you put, it's going to help us and your client and you more. So these are important even if it's not an AOT referral, because it will raise the risk score of the client when it comes to assigning them to services. We'll talk about that a little bit more. Okay, so here we have a submission note. Any other information that you think we might need that wasn't covered, put it in there as much as you can possibly provide. We want as much as you will give us or can give us. Okay, and that's it. We're at the end. So it's not, I don't think it's too bad of a referral. There's not too much information. So up here, I'm going to show a couple of things. So this is where you would submit referral. It is kind of in a weird area, but it's at that drop down arrow there, submit referral. And then I'll show you where you can get the consent. So we're going to go over consents in a little bit, but I will show you now. So general consent form, that is required for every referral that comes in. That's the SPOA consent, we call it. It's the general consent form. You can get it right there. Pull it right up. In the AOT consent form, that was only required for AOT referrals, is under the arrow next to more, and it's right there. So you can get those and upload them right into the referral. Okay, we're going to go back to the PowerPoint now. So any questions while we're still in here, definitely.
One question that came in, Andrea, is, are there any differences between the Erie County and Niagara County application process?
So our office only does Erie County. So I can't really speak to them. So they would be different. But I know they're different because I've heard a lot about them. I've actually looked at theirs. I think their referral is longer and more involved and more, but maybe a bit more informative. But I don't know the process. I can't really tell you for sure because we only do Erie.
And another question, are you using electronic signatures?
We do not, no, we don't use electronic signatures. So we are asking that you get, I guess if you wanted to turn the consent form into a PDF on your end and somehow get them to sign it electronically on your end, get the individual to sign it. But for us, we need the signed consent. However, you're going to get that to us, and we would require it by you uploading it right into the referral, or you can email it to us if you're having issues with uploading.
Another question that just came in, are individuals who have refused mental health services or linkages, have mental health diagnoses and homeless, do they qualify?
So refused
mental health services or linkages.
Well, if you're not putting in a referral for assisted outpatient treatment, which is the involuntary category, if you're putting in for general care management, they would need to be voluntary and agreeing. If you're putting in for assisted outpatient treatment, that's the involuntary part of things. I hope if that doesn't answer, feel free to clarify. So I guess if you're asking too, if it's somebody who refuses, let's say they have a diagnosis of schizophrenia, they're refusing clinic and medication, but they're willing to get a care manager, that's fine. Care management, we can definitely make a referral for a care management if the client is not linked with mental health treatment. Otherwise, they would just need to have the documented diagnosis and the care man, and of course, still be safe for a care manager to be working with. And that would be something I think typically most of the care managers would try to work with, getting them to the point of being able and willing to engage in clinical services.
Another question for you too, Andrea. Can a disabled individual or an individual with an intellectual disability come to your office and receive assistance to complete the forms?
I would probably take a phone call from them first and try to assist them by phone. And then we can kind of go from there with it. I know that there are places such as the ECMC Help Center where people can go to get assistance with those kinds of things, filling out referrals. But I would definitely try to walk them through by phone first.
Okay. That looks like all for now, Andrea.
Okay.
Thanks.
Bear with me. I'm going to pull up back to the PowerPoint. There it is. Look good? Can you see it?
Yep.
Great. Okay, so we're going to talk about our favorite subject a little bit more, is the consents. So again, the SPOA consent must be filled out correctly, signed by the individual whose services are being requested for, and uploaded to every submitted referral. So I just showed you where it can be located, but it is eriespoa.org, referral submissions, and it has its own section, general consent form. And again, the referral will not be accepted without a completed consent.
I have a question that came in for you, Andrea, if you have a minute, and I think it might go back to the referral. It says, is there a way to override a particular situation when a client's mental illness is a barrier?
A particular situation, so if you're saying a barrier to getting services, clarify that a little bit in the chat, and Kathleen can get right back to me on it. I'm not sure if we're back to them signing the consents willingly and voluntarily again, or if there's something different to it. So Kathleen, just interrupt me when that's clarified.
Sure.
Okay, all right. So I did an example of a consent here. It's not the greatest quality ever, but you can probably get the gist, and you might be able to pull it up better on your own if you want to refer back to it later. So this is the general SPOA consent. I'm really just kind of showing, the information that we need. So definitely name and date of birth, super important. The good rule of thumb is to all of everything is what we want. Like, if you don't have to limit it, let's not limit it. So all of the records available, you know, the information can be disclosed to anybody. Any person can provide information. And then here is kind of hard to see, but I'm sorry, this is the expiration, and we would always be looking from like a year from the date of the signature. That is the best thing to put there. And then this section, the number 9, I believe that is, we don't want to limit permission if we don't have to. So just giving as many permissions as you can as you're filling out this consent. Client signed and absolutely date as well. So the AOT consent is a little bit more involved, a little bit more information is needed on it, and that's because that is the consent that we are using to request records. So that is the second piece. So you need the SPOA consent and the AOT consent when you're putting in for AOT specifically. So again, it must be filled out correctly, signed by the individual the referral is being made for, and uploaded into the referral. That one is located, it's a little bit harder to find, located at eriespoa.org, referral submissions, the more drop down, and then the consent form is right there, labeled AOT consent form. So again, a referral will not be accepted without a completed consent. So here's an example here. These are really kind of specific, the way we like these to be filled out, because it really depends on what information we're going to get from the hospitals where we're requesting. So I did put some important notes here because I know that this is kind of hard to see. So demographic information should be filled out completely. So up top here, we need the social security number, we need the date of birth, the address, make sure everything is filled out. So box number 8, that is like what we are asking for, what we're requesting. We do not want the entire medical record. The first option, medical record from 48 months prior to and entering the date, is what should be chosen, along with admission, discharge summaries, etc. And the client should initial the alcohol, drug treatment, and mental health information. When we check entire medical record, which we do, and it's fine, we'll still send it. We will sometimes get thousands of pages sent to us from every admission the person has had, you know, since the beginning of time. So it's a lot. It's too much. So we are actually we're currently working on getting the consent changed. It's just not a real easy process. So for now, this is kind of what we're asking people to do. Box 9, that is where our basic hospitals that we are always requesting from are located: Erie County Medical Center, Buffalo Psych Center, Niagara Falls Memorial. A couple of them don't really exist anymore, but this is where you can also put others. So the out of state or the different areas in New York State hospitals, add those in here in these boxes here. Super helpful. Box 11 will always, for some reason, be a problem. It's always forgotten, and that's the expiration date. So box 11, don't forget it, put it in there. And client and witness signature is needed for the AOT consent. So you're doing the referral for somebody, you could be the witness signature.
Andrea, we have a clarification of that question when you have a second.
Yes.
They said when a client refuses to attend appointments to get the SPOA forms completed, or the client doesn't have medical history with a new PCP to get the forms completed.
They have to. So my general answer to that is any other than AOT, care management and ACT are completely voluntary. So the client has to sign the consent. There's no, yeah, so that's the answer. I mean, depending on your role with the person, you can send it to them in the mail if they're not coming into appointments, have them send it back. But yes, they need to sign it if it's a voluntary request that's being made.
And then one other question, does the referring agency have to provide confirmation of diagnosis?
That is a really good question. We are going to get there. The short answer is yes, but we're going to talk about that a little bit more going forward. Okay, so the importance of a complete referral. So a complete referral has accurate and detailed hospital information. The lethality section is fully filled out. The demographics and contact information are up to date. Your information as the referral source is put in. So diagnosis with verification if available. So yes, if normally if it's a hospital, a clinic, it's pretty easy for them to upload and give us, you know, a psychosocial or a psychiatric evaluation. They could just upload that right into the referral. If you don't have it because of the role that you're in with the person or for whatever reason, you don't have to put it in the referral. We do have the ability to look in psyches, and so we will look in psyches and see if we can pull it that way, which usually we can. But if we run into a situation where the person doesn't have Medicaid or the diagnosis is not listed in psyches, at that point we will then be brainstorming with the referral source. Okay, you know, your agency doesn't have that information. We know he has this diagnosis. Where can we get it from? So we would be looking for that. And I believe it just has to be a qualified health professional who is signing off on it. So we would brainstorm, we would do what we can. And usually we can pull it from psyches. So good question. Collateral contacts, we definitely want all of those in there. And here I am saying it again, consent's completely filled out and accurate. So an incomplete referral will have no hospital information or really incomplete history, nothing filled out in the lethality section. It just gets skipped over completely. Contact information is missing. We want to know what is your relationship to the referred, phone number, email address. You know, we've gotten some that come in before where it's from a Gmail address. Maybe somebody just accidentally used their personal instead of their work, and it really, you know, we would have no idea who it was that made the referral source. So definitely making sure you're as clear as you can. So no diagnosis or not a SPOA accepted diagnosis, no collateral contacts, and the consents are missing or filled out incorrectly. So the importance of a complete referral, the more information in the referral, the higher the risk score. It allows SPOA to know where to request records from for AOT referrals, and super important part, it gives the ACT team care management agency an accurate description of the client they will be serving. And the more information we have, the quicker we can assign, bringing the needed services to the client in a timely manner.
2 questions, Andrea. The first is, does the expiration date have to be within a year, or can a client say never? And I think that's referring to the consent.
I can say never, but I guess my own opinion was I don't know if writing never would be good, but like if you maybe do 5 years out or something like that, I think would probably be good.
All right, and then the second question is, can Healthy Link be used for diagnosis?
That's a good question. And I don't know the answer to it. So I guess if we're asking if the referral source can see, no, I think that would be third party on your end of providing that. So I don't think so. It has to be from your agency or from somebody who directly serves the client. That would be my answer. So if you got something from Healthy Link and you copied it and put it in there, I don't think that would work. But good question. Okay, so you submitted a referral, now what? What happens next? So for general care management, the referral is reviewed by a member of our team. We're looking, is all the information filled out? Is the consent attached? Can the diagnoses be verified in psyches, or was their diagnosis verification uploaded? And does the client have Medicaid? So once reviewed and determined it is appropriate, the referral will be assigned to a care management providing agency. The assigned agency will then be in touch with you or the referred individual to schedule an intake or screening and move forward. So non-Medicaid general care management. We do have non-Medicaid slots available. So regardless of insurance, anyone eligible can be assigned a care manager. However, of course, slots are limited. So a referral for somebody who has, you know, straight independent health, straight Blue Cross Blue Shield, Medicare only, they may end up on a wait list for the non-Medicaid care management. So assertive community treatment or ACT referrals. So ACT spots are very limited and highly requested. We are always on a wait list for ACT. If we cannot assign to ACT right away, we will reach out to the referral source, with other alternatives, such as other community team options, some general care management. Okay, we can't put them with ACT right now, but at least let's get them a care manager, at least give them a little bit of extra service, extra support. And then clinic information if the person making the referral source isn't aware of maybe what clinics are available, what's close to the person who they're referring. So the waitlist is assigned when there are openings, and it is based on risk score and need. So that is kind of going back to why a referral should be complete and accurate, is because the more information that's in there, the higher the risk score is going to be. So it will help you and the client going forward. So we will reach back out when there is a possibility to assign. When the referral is assigned, it will be up to the individual ACT team to accept or deny after completing a screening. So when we are assigning somebody to an ACT team, it does not mean that they're being enrolled with the ACT team. The ACT team then is able to do their own screening and decide if they will be accepting the person or not. Okay, so after a AOT referral is put in, so a member of our team will request hospital records based on information in the referral. Again, it's important to be accurate so we know where to get these records from. So just for your knowledge, it can take some time, up to a month or more, to get the records that we're looking for, or sometimes they come the next day. There's really no rhyme or reason to it. So once the records are received, we will investigate if the referral meets AOT criteria, which we had gone over in the beginning of the slides here. So if they meet criteria for AOT, we will then move on to the next steps. So we will determine a treatment plan with your assistance. Usually the people putting in AOT referrals are hospital social workers, clinical social workers, etc. So AOT individuals can be care management plus clinic or ACT, and it's kind of depending on their history and their need. We will work to schedule an AOT evaluation, which requires a physician willing to complete the evaluation, sign up on the paperwork, and attend a court hearing. So if the individual does not meet criteria for AOT after our investigation, we will reach back out to the referral source to see if just general care management or even an ACT referral is appropriate or needed.
I have a couple questions, Andrea. The first question is, are you able to submit a paper copy of the application, or is the electronic version the only acceptable version?
The electronic is the only acceptable version.
And the second question is, if someone is already receiving care management through a health home and they want care management through SPOA, would they have to disenroll from health home care management first?
So SPOA care management is health home care management. I think I've actually gotten this question before. It's health home care management. We're referring, and we'll pull up what agencies that we're sending referrals to. But if you're thinking about Honey or one of those other, we're referring to the same agencies as they are. We are just a different referral source, I guess is the best way to put it, a different funnel of who's sending the referral out, basically. So there wouldn't really be a reason. There wouldn't be a reason if they're happy with the services they're getting and they're happy with the agency that they're with, there wouldn't be a reason to put a new referral into SPOA. If they're not happy with the agency that they're with, or they're having issues with their assigned care manager, that would be a different conversation. But basically it doesn't matter where the referral is coming from. We're all kind of referring to the same agencies. So is that it? Okay. All right, so I just get some frequently asked questions here. Okay, why was my referral rejected or marked incomplete? We will usually provide a reason to referral source. Likely it was because there wasn't a consent or it wasn't filled out. There isn't an SMI, or because they're already linked with services. That will happen a lot. We're looking in psyches not only for insurance and diagnoses, but also to see if they're already linked. And a lot of the times referrals are getting put in where psyches is showing us that the person is already linked with a health home care manager. So those are a lot of the big reasons. And when a referral is marked incomplete, it will go into a separate category in the way we view the referrals, and we won't really see it. It won't pop up on our main screen until the information needed is provided. So make sure when you're being told you need to put a consent in or whatever the information is that you might need to add, that you are doing that, because it doesn't quickly come on our radar. Will I hear anything after I submit a referral? And that kind of depends. We might reach out if we need information, but if the referral is really cut and dry, everything's complete, we have everything we need, we won't necessarily reach out. We will just assign it, but you should get an an automated email saying that it's been assigned and what agency it's been assigned to. How long will my referral be on a wait list? There's really no set time to be on the wait list for non-Medicaid or ACT services. It depends on the need and availability of services. If the ACT wait list, I would say right now is 60 people deep. It's pretty bad. So I do like to reach out when I'm telling people that I'm putting their referral on the wait list and make other recommendations. But we would always ask too that you reach out if there's changes in the person's status. If somebody is on the non-Medicaid wait list, but they get Medicaid, you definitely want to let us know that, because they'll be able to get services a lot quicker typically. For ACT, if somebody ends up in the hospital or has a really serious incident, reach back out to us, because it might up their risk score and up their ability to get assigned. So we would want to know that information. Can I request a specific agency to be assigned for care management or ACT? You can, and we'll try, we'll do our best to make it happen, but we do assign based on availability, what slots we have open. What if I'm having issues with the SPOA site? You can hit contact support on the top of the referral under more, or you can reach out to somebody in our office, and all of our information will be at the end, and we will assist you the best we can, which is usually likely just putting our friend Doug on an email and having him handle it for you, which he will pretty quickly. So, okay, so why can't someone with a personality disorder or anxiety or depression get services? So unfortunately, the services have to be limited. It's a real case of the need is greater than the availability, so we have to limit it to the SMIs. However, we do want to be able to help however we can, and we ask that you reach out if they have a diagnosis that isn't typically accepted by SPOA, so that we can kind of explore other options and referrals. Okay, so here are the SPOA agencies. So for ACT, we have Best Self Behavioral Health. There are 2 teams through them in Spectrum, and there is 1 team through them, Buffalo Psych Center, 1 team, and all of that teams except AOT patients. Care Management, BFNC, Best Self Behavioral Health, Buffalo Psychiatric Center, and Spectrum. And those 4 do general care management, Health Home Plus, and also AOT. And then we have Evergreen, Sync, Harmonia, Hillside, Horizon, Monroe Plan, TSI, Venture Forth, and Community Services for Everyone. And those are our general care management, Health Home Plus, non-AOT agencies. So here are our contacts. I think I just saw a question pop up on that. So we have the main email address, care@eriespoa.org. And if you email that, it will come to the 3 of us. We have our SPOA coordinator, Nicole Jordan. I am one of the 2 assistant SPOA coordinators. There is my name and email, phone number. And then Ellen Mills is the other assistant SPOA coordinator, and her information is there. I did want to make a note, because I know housing is obviously a big piece of SPOA as well. I did want to make a note that Christine Slocum did a training similar to this on the housing specific stuff back in July. You can locate it on the saved trainings on the website there. And she was July 26, 2022, and all of her information is there. So you can locate that recorded training and the PowerPoint and everything right there. So for housing, it would be Christine Slocum and Joshua Curry. Lipscomb. And that is the end.
We do have a couple more questions that came in. One is, do you have a referral resource list for those who may not meet criteria?
That is a fantastic question. We don't have an official list. That is something we've talked about recently, is getting something like that together, but we do have the ability to kind of pull from the information that we do have to help the best we can. But hopefully more will come on an official referral and resource list down the road.
And then this goes back just a little, how and who can we get in contact with when changes are made? I know you provided your contact information, but just maybe pointing out who they can contact if changes or when changes are made.
So I'm assuming maybe changes in the person's status as far as if they're on a wait list. Just email us. I mean, all of our information is there on the training, on the website. You can do, I think you can just hit contact support and it'll come right to our care email. So whatever, however you need, however you do it. Yeah.
There was someone who asked about your slide again with the coordinators. We will be posting this PowerPoint presentation along with the recording to our website after the training, and then it'll all be posted, I'd say, within the next couple days, so you'll have access to all of that information. And then one other question it looks like is, do you know where to find the children's SPOA application?
I should probably know. It's a different office than ours. I think if you go, Amy or Kathleen, do you know that? I think if you go on the the Department of Mental Health website, I think you probably could be directed to it from there.
Oh, Amy says, hold on.
Okay.
And yep. And then Amy actually has posted, and what we'll be posting here in the chat is the links for our future trainings. We also will be posting in the chat, and we're asking everyone to take a minute to complete our evaluation. It actually looks, as I'm scrolling through the chat, that there may be a couple people who posted links to our children's SPOA application. So if you go into the chat, it looks like John and Josh both posted the link to our children's SPOA application. So thank you so much.
Yes, thank you.
And I think that looks like all of the questions that came in. So I'd like to thank you, Andrea. That was a great presentation. Thank you so much for providing all that information. Thank you, Amy, as always, for coordinating, and thanks everybody for participating today. Amy is pasting the link to our evaluation in the chat box, so please just take a moment to complete that for us. It's only a few brief questions. Again, just to reiterate, the recording of today's presentation and PowerPoint will be posted on our webpage, so please go to our website within the next couple days if you'd like to look at that information. Registration links for our next two trainings, both our 2nd April training, which is barriers to reentry, and our May training, which is self-care, are posted in the chat as well. However, you can check our website for all of that information. If you're interested in being a presenter, please let Amy or I know. If you have ideas of topics you'd like to learn more about, you can put that in your evaluation as well. Thank you, Andrea, for a great presentation, and thanks to everybody for participating.
Thank you, everyone.